Hello. So today we're going to talk about modern IOL technology, which is area of a lot of passion for me, and I think it's really cool that we're so blessed with more and newer and cooler technology kind of every year in the IOL space. So first, I think it's important to kind of understand the context of how we got to IOLs. So the history of cataract surgery, really. The earliest descriptions of cataract surgery were actually kind of in ancient Egypt. So it's called couching. So what somebody would do is recognize that a person had a cataract. Either their eyes were white or if there was obvious like brown obstruction in the eyes. They would take a needle, heat it over a candle, and enter kind of through the limbus and disrupt all the zonules that were holding the lens capsule complex in place, and the whole bag capsule lens complex would fall into the vitreous space. Obviously, you're leaving these people like plus 10, plus 11, so it's not good vision, but it's bright again. You can kind of see colors again, and it was better than having the cataract. The kind of next innovation was like in more like 1600s. It was called extracapsular cataract extraction. Obviously, we didn't have IOLs yet, but the lens was removed through like a large opening, and again left aphakic, so left kind of without a lens. Intracapsular cataract extraction was like a 1700s thing. That's where the an even larger incision was made, and the whole lens was kind of removed in one go. Phacoemulsification is where we would make small corneal incisions. This was only possible in 1967 when the idea of phacoemulsification was possible. That's where we use ultrasound energy. So basically, the tip of the needle is moving at the speed of sound to liquefy the lens and make it easier for removal. This means it could be done through extremely small openings. So the lenses had to be smaller, or foldable, so they could be inserted through these. But this was a much like more astigmatically neutral way to do cataract surgery. Manual small incision cataract surgery, which is often done in developing countries, mission trip type work, actually was developed in 1994. It's also kind of a smaller incision and a mechanical fragmentation of the nucleus where it's kind of like delivered, like the whole lens is kind of scooped out. The kind of most recent innovation of cataract surgery is micro incision cataract surgery in 2002. There's only a couple of lenses that can fit through these really small openings, and it uses like a bimanual technique instead of a coaxial phacoemulsification, and it hasn't really caught on. I would say it's really like phacoemulsification with extracapsular technique is what's common today. For a lot of human history, though, there weren't IOLs, right? So from the ancient Egyptians to the French in the 1700s, we're just leaving them aphakic and either using the huge Coke bottle glasses or doing what we could. But the first IOL was in 1949. I like to tell patients a story because I think it's pretty interesting. But a World War II, an English World War II pilot named Mouse Cleaver was flying a Hawker Hurricane, which is like a fighter plane in World War II. He was shot down. He sustained multiple injuries and was treated in a hospital in London by Sir Harold Ridley. He noticed that there were actually fragments of the windshield of the airplane in his eye, and he noticed it was like actually quite inert. So there wasn't a lot of inflammation. There was no infection, and the eye and body seemed to tolerate the material quite well. The material was acrylic, which, spoiler alert, most of the lenses are made from today. So he had the idea in 1949 to implant the first IOL. It was done kind of after a patient had already had cataract surgery, so I guess you could call it a secondary IOL. There was a minus 18 spherical equivalent refractive error, so it wasn't perfect, and all the calculation nuances obviously weren't understood at the time, but it was kind of an interesting story on how this came to be. In 1978, the first foldable IOLs were available, again, to kind of correspond with phacoemulsification. So phacoemulsification allowed for cataract surgery through these really small openings. So we kind of needed technology to catch up to utilize them, so we didn't have to keep making huge incisions to insert lenses through. The first toric IOL, so for astigmatism correction, was in 1998. And that's also the year of the first multifocal IOL. The first multifocal IOLs were all refractive, so they worked a lot like bifocal glasses, where there were just different refractive zones for the lens. The first diffractive IOL, though, was in 2005. I'll talk about diffractive lens technology in a second, but it's kind of a step up over the refractive IOLs. The first extended depth of focus lens was in 2014. And then in 2017, the light adjustable lens was available, which is a really cool innovation that allows adjustment after surgery. I'm a big PBS guy. I grew up watching PBS, so I still watch their Eons videos on YouTube, which is just educational stuff about natural history and things. They had this video that was really funny. Their question is, why do things keep evolving into crabs, which is kind of ridiculous and hilarious, but it's true that kind of throughout natural history that kind of crustacean body plan was favored. So with enough time, a lot of animals kind of adopt a similar body plan. As kind of the spoiler for the video, but I bring that up to kind of talk about IOL anatomy. So most IOLs today are single piece, square edge, and hydrophobic acrylic. They all kind of share similar features. So there's an optic in the middle. It's almost always 6 millimeters, and the length with the haptics is almost always 12 or 13 millimeters. It's usually 12 millimeters for a single piece. For square edge lenses, the reason they're square edge is just to prevent the migration of remaining cortical cells behind the lens to cause a PCO. The rounded edge lenses might make that more possible. Everything's kind of a trade-off. So with a square edge, you might get more dystrophias. For material, there's really 3 options today. There's acrylic, silicone, and PMMA. Acrylic is flexible and foldable. It's the same thing as the Hawker Hurricane windshield from 70, 80 years ago. The silicone is also extremely flexible and foldable. It has an excellent dysphotopsia profile because it's just a good material to be looking through. PMMA is rigid, rarely used. It's not foldable, so you have to make very large incisions. Back to optics, I can't get enough of it. So the spherical aberration is kind of a fact of nature. So that just means that peripheral rays, light entering from a light source, peripheral rays, do so at a greater angle than central rays, so they're refracted to a greater degree, which means they typically focus anterior to the central rays or the primary focal plane. Your cornea has a way to offset this, but so do all the IOL manufacturers, and it's kind of on a spectrum. It ranges from the normal human cornea has a little bit of positive spherical aberration. So the companies usually incorporate negative spherical aberration to offset that. Luckily, there's kind of a range, so you can this is something you can use to tailor an IOL to a unique cornea or something, because they range all the way from negative to some of them are positive and actually induce spherical aberration to get a kind of EDOF effect. The optics are all very similar. They're typically biconvex, which just means they have the convex shape on both the anterior and posterior surface. Plano-convex and meniscus lenses are usually kind of the minus lenses, but those are rare. Most of the average lens power is really between 18 and 20. That's the majority of IOLs. So diffractive multifocals, instead of using actual refractive rings or refractive zones, use these little echelets to more precisely manipulate light to create multiple focus distances. So most of the trifocal or multifocal IOLs utilize this same technology. Extended depth of focus lenses are similar. One thing I always got confused on was what the difference between depth of field and depth of focus was. So you have to kind of think back to camera. So depth of field is how, if you're taking a picture, how out of focus background elements are compared to foreground elements. That really doesn't have anything to do with the focal plane. It's just, size of aperture and different things like that affect that. Depth of focus is what the actual lens is doing to the focus point, whether it's focusing all light to a single plane, as most camera lenses do, versus kind of spreading out that focus point to more of a focus range, which would be depth of focus instead of depth of field, which is more what these IOLs do. Most lenses are biconvex, and most of them do correct for spherical aberration. I brought that slide up at the beginning just to make a little joke about, so like, why do IOLs keep evolving into single piece, hydrophobic acrylic, spherical aberration correcting biconvex lenses? I mean, really, most lenses released fit this profile. And that's just because, it's what works. The hydrophobic acrylic material has really shown to kind of have the best trade-offs with like glistenings and calcifications, and most of them are spherical aberration correcting. Like I said, and the biconvex design is really best for these high plus lenses. So to start, we'll kind of start at the top and work our way to the bottom. So multifocal IOLs, there's multiple options on the market today. So there's the Tecnis Odyssey, which is a J&J product. There's the B&L Envy. There's the PanOptix Pro. All three of these are diffractive, hyper modern IOL platforms, and they all perform really excellently. The Clearview SBL3 is another multifocal. It's like a bifocal lens, but uses refractive optics. It's rarely used in my experience, in the U.S. at least. So who are these like lenses best for is another question that you kind of have to learn over time. And it's for multifocals, it's somebody that just desires spectacle independence. Like they don't want to be wearing glasses afterwards. They have like active lifestyles. They're intolerant to glasses, and they wouldn't mind like the temporary halo and glare. These lenses, you saw those echelettes, there are rings in these lenses. Just like the ICL, you will see the rings most likely for a short amount of time. The literature says for most people, by 6 months, 98% of people don't see the rings anymore, and the rest just take longer to go away. So it's just kind of something you have to adapt to, but you just let your brain do it, and it will. Who are they not ideal for? Somebody is extremely particular, and you think the glare would annoy them or the lens would annoy them. If they're like post-refractive with a large treatment, it's just generally not a good idea to stack things. So if you have a aberrated cornea from like a previous RK or something, and then you have a multifocal IOL underneath that, it's kind of a lot of optics going on, and it can kind of degrade visual quality overall. And you really need healthy eyes. So if there's like macular disease or early signs of AMD or kind of more advanced glaucoma, there's really no free lunch with any IOL. There's only so many photons entering an eye at any single time, right? So these lenses work by dividing that light and strategically utilizing it over multiple distances. They typically dedicate about 50% of the light to distance, and the rest of the light to both intermediate and near. So if you have an unhealthy macula or some sort of other eye disease, you need all the light you can getting to the back of the eye and dedicate it to kind of one focus point, or else you're not setting patients up for success. This is just a really quick video showing like the PanOptix Pro, for example, being implanted in the eye, and you can very clearly see those rings there, and the lens very easily foldable and inserted through a very small opening. So these extended range lenses are kind of becoming more common. The first one was, in my opinion, kind of the Tecnis or iHance. These some of that didn't quite fit the criteria for EDOF lens, but it did have it's kind of like what we call a monofocal plus. There's also the J&J Pure C, which will be a true EDOF, which should be released sometime in 2026. The Aspire is a similar, what I would call monofocal plus, not quite true EDOF, a B&L lens. The Vivity is a true EDOF, not as common. Again, in my experience, there were some issues with like significant loss in contrast sensitivity. And then the Ray 1 EMV, which stands for enhanced monofocal, also is a kind of enhanced monofocal plus lens. So the right fit for these is really someone who desires some spectacle independence, good for blended vision, and if your eye is like not quite healthy enough for a multifocal, well, everybody can still have an iHance or like an Aspire, even with like macular disease. They're just not manipulating light to a significant enough degree to really impact final visual outcome. They're really not ideal for just really those people who are like really desiring a single distance as good as they possibly can, and they're not great for like if you have unrealistic expectations about glasses independence. If you have like a macular disease and we choose one of these IOLs, you're going to need glasses at some distance, essentially. And then there's the monofocals, so these are like the, Technis platform lenses from J&J, the Clarion Acrosoft, the Invista lenses, and then like Softport is a silicone lens. So the right fit for these are really people who desire best vision at a single distance. You've had success with monovision in the past, and your eyes are, again, too unhealthy for a multifocal. They're really not good if you really want a spectacle independence of any kind. You can do some blended vision strategies, but you're typically better off with using a monofocal plus or extended range lens. I do realize on this slide the labels for the Invista and the Clarion are backwards, but that's okay. There's the Softport is also a great lens for like a piggyback IOL. So that's just where we add two lenses to the same eye. So this is just, a very low plus piggyback lens being inserted to, correct a little bit of farsightedness after surgery. It can also be used to like move refractive targets a little bit closer. And it doesn't require laser or anything. It's a super simple procedure. And like I said, the silicone material is like really, really forgiving as far as dysphotopsias and things. And it's also like obviously a really, really quick and easy procedure just to add another lens on top there. So there's also specialty lenses like the LAL. So the LAL is really cool because it allows for like 4 diopters of adjustment after the procedure that can either be in sphere or cylinder. And it's good for certain people. So one is if you want to test drive blended vision. That's to say like, hey, they can come back and say, I wish I could hold things closer to read, and you can move the, near eye a little bit closer or move it back out. And, it really gives people a chance to, test drive what, they want to live with. It's also good for people who need like maximum precision. And it's also good for people who have had a type of refractive surgery in the past. So if you had LASIK or RK or something, and, your refractive target is inherently more difficult to nail, the LAL provides that wiggle room that will kind of give you the best chance for nailing the target. It's the only people it's really not ideal for. It's adjusted with a UV laser, usually starting at 2 weeks to a month after implantation. The sun is a UV laser, so while they're outside, the company recommends the patients wear either clear UV protecting goggles or the sunglass goggles, and it also has to be adjusted and locked in. It has to be locked. Come back for 2 lock-ins. At every adjustment and every lock-in, you have to be dilated. So if it's going to be difficult to accommodate that kind of adjustment and lock-in schedule, it's not ideal. It's kind of a lot of coming back to the office. And if you have like really bad corneal scarring or really irregular astigmatism, it can adjust for lower order aberrations, but it can't yet adjust for higher order aberrations, essentially. And here's just kind of what the LAL looks like on insertion. So it's also a silicone lens. It kind of, the company says it has a champagne color, kind of like that. The champagne color is actually something called Active Shield, which is a UV protector. In the kind of old days, you had to wear the goggles in the shower even. But with the Active Shield, it kind of provides a little bit more protection. So the lens can be adjusted more precisely without the fear of like ambient light causing any problems. Here's what those adjustments actually look like. So the adjuster kind of finds the center of the lens itself. You focus on the haptics and you kind of just perform the adjustment and push the button. You plug in patient's current refraction, desired refraction, and the machine kind of does all the math. And you kind of just, the patient kind of just sits in what looks just like a slit lamp for, you typically between like 1 to 2 minutes. And then that usually kicks in like a day later. And I think it's good to tell people they might have like pink tinted vision for like up to a day too, just because of the amount of bright blue light that's being shined in their eye. They might also have some like dryness afterwards, but the treatments are usually like pretty comfortable and benign. I like this slide from a different presentation I did, but kind of like something spooky looking at you from the dark. What could that be? The old IC8 lens. So another specialty lens is the IC8. It is unique in that it has a mask in the center to kind of create a pinhole effect. So Its intention was kind of twofold. So one, by creating the pinhole effect, just like any miotic drop for presbyopia or something, or like the pinhole visual acuity, you could increase kind of depth of focus by doing this, by using the pinhole principle. If you had a very irregular cornea, it was also kind of good to ignore the rest of the irregularity and kind of only focus on the central cornea so you're looking through less irregular cornea. So it really kind of was best for those with advanced corneal disease, and you would typically only do it in the non-dominant eye because it was less light in the eye, right? So it will cause like a dimming in that eye. It's not really used that often anymore, and I'll be totally honest, most of my experience with this lens is actually removing them. So I personally removed a couple of these and just replaced them with the LAL instead. They were a good idea, but just not used as commonly anymore, I would say. Another kind of specialty lens I would say is the CT Lucia. It's just kind of unique because instead of a PMMA haptics, which is what that the haptics are typically made of on 3-piece lenses, it uses something called PVFD, which is just more forgiving to manipulation. Like it's very easy usually to kink 3-piece IOL haptics, but this material allowed for better. They were just sturdier, and it was a more flexible material in that it couldn't get bent out of shape as easily. Who loves this? Really like our retina friends. So a lot of Yamane technique, like scleral fixated IOLs, are used with this lens, but outside of that, it's just really not as common in the United States, at least. There's lots of cool stuff on the horizon, cool stuff coming out all the time. So for the multifocal IOLs, the BVI Fine Vision, the Zeiss Elena should be here for both of those. We were actually at FDA trial site, so I have some early experience with those. The Rainer Galaxy lens is kind of a novel approach to a diffractive multifocal IOL. That should be coming to the United States soon. The J&J Piercy was another EDOF IOL that I mentioned earlier. The results from the clinical trial that we did with that were excellent. So, very excited about that lens as well. But this is just what I mean. There's new lenses coming out like all the time. And it's never been a better time in all of human history probably to have a cataract. Here is a cheat sheet that's available on IOLreference.com that we make. So this is IOLreference.com is a website that kind of serves as like a neutral database for every single FDA approved IOL in the United States. There's no like industry support for it, so it's just like a totally free resource. And we also publish these common IOL sheets just for kind of quick reference. If you find it helpful, we keep it updated really regularly, and that's kind of the best way the industry supports it, is just to kind of let us know when new things are coming. So that's another good resource for you, and excited to see what's on the horizon. So thanks again for your attention.